Real talk. Real topics. Real solutions. This is MSR Forefront with your host, Stephanetta Harmon.
Good evening, everyone. Welcome and thank you for tuning into our latest edition of the MSR Forefront, where we are committed to authentic conversations with elected officials, organizations, and thought leaders on issues pertinent to Black communities in Minnesota and beyond. I'm your host, Stephanetta Harmon, and tonight we are talking Black maternal health. Study after study shows that Black women face unyielding health disparities across the board, and tops on that list is maternal mortality and injury. In layperson's terms, Black women are dying. We're dying at much higher rates than our white counterparts, and if we're not dying, we're also experiencing high infertility rates, lack of access to alternative support and resources, and we're pretty much just left voiceless. And so I want to have this conversation. We've brought on three important experts in this conversation. Akmiri Sakira, who is the Chief Family Development Officer over at Cultural Wellness Center and a perinatal educator. Rhonda Fellows, a birth doula and a childbirth educator. And Dr. Kathleen Cools, obstetrician and hospitalist at Alina. How are you ladies doing tonight?
Good,
wow,
thank you.
how are you?
Wow.
Welcome. Thank you so much for joining in on this conversation. As I was saying before, I want to make this as conversational as possible. You know what I mean? Like this is our kitchen conversation where we can really get into what's going on. And just before we do that, I want to kind of get you to explain to our audience who you are and what you do, because a lot of people don't know what a birth doula is or a hospitalist. Sis Akmiri, can you start?
Mm-hmm. Greetings, Hotep. Akmiri Sakira. I work for the Cultural Wellness Center, where I am the Family Development Officer there. I'm also a perinatal educator, which is a doula, really. I've been a doula for close to 30 years. And I was probably a doula when Black people didn't know what a doula was. They just thought it was an auntie or something. Because usually when I'm in a room, I don't announce that I'm a doula. I'm usually just there working with the mom, working with the families. And so that's the work I do. I'm at a point in my life now where I'm really trying to mentor and train other doulas of color, so Black doulas, to be able to work with our families and to realize that we all have a culture. And we need to celebrate that culture for our babies. Babies are conscious. Babies know what's going on. And so I really want people to understand that and to know that. So thank you for this opportunity.
Thank you. Thank you so much. Rhonda?
Yes. Hi.
Hi, how you doing?
I'm doing well. I'm excited to be here.
Yes.
Like Akmiri said, I am a birth support. I do childbirth education as well. So I meet with families in their pregnancy time. Some actually come before they're pregnant, ask questions about getting pregnant, who can they go, who can they go to for fertility help. So I can direct people, but also once pregnant, I meet with family in their homes, well, pre-COVID, a lot virtually right now. Throughout pregnancy, as well as teaching childbirth education classes to my clients, but also to other families in the community. And now that that's virtual, teaching to families in other states as well. And then I'm with families during their birthing time and then their immediate postpartum, those first couple hours after birth, and then go back in the home once they're home with their babies.
Thank you. Thank you so much. Welcome. And Dr. Cools.
Thank you for having me. So I am a hospital-based obstetrician, which essentially means I'm a part of the team that is in the hospital 24 hours a day, 7 days a week. Typically take care of the patients whose doctors don't come to the hospital that I work at, and I'm also there to help with emergencies or assist other obstetricians as well.
Okay. Thank you. Welcome. So let's get in. Let me first say to our audience that's tuned in, if you have any questions, please feel free to drop them in the comments. We're here for all of the comments, all the questions and conversation. And let's get into, I guess, what's the biggest issue that you are seeing right now when it comes to Black women in healthcare, in maternal health care?
Hmm.
Who wants to start with that one? Is it so? Well, is it the disparity? Is it the death rates? Is it the lack of access? Like, I mean, it's all bad.
It's I find it to be so complex and so many different issues. So yeah, it is. So it is the disparity. It is the access to care. It is comorbidities, so chronic illnesses. It is also, of course, institutionalized racism as well, contributing to this disparity. So it is such a large combination of things.
Okay.
Yeah, this is true. And it's also true that this has been going on for years and years and years. And now all of a sudden it's at the forefront. And because two people in the media they were treated badly, and that's Beyonce and Serena. And so now people are like, this has been happening? Yeah, it's been happening for umpteen years and then some. So
well, part of that.
Yeah, in addition to what they said, I would also say education is lending to the problem that's already there. Lack of education, I don't believe it has caused the problem for our people, but it is lending to our families not knowing how to protect themselves, how to advocate for themselves, to know their rights and choices. So I think that adds to the problem that the two already explained.
And so when we think, I know when I hear it all the time, especially when we're talking like, well, Serena reported about, I think her, the issue with her veins or whatever it was, that she was telling them that there was an issue and she wasn't being heard. And we present a lot as Black women. We know our bodies. If anybody gonna know their body, it's gonna be us. And we show up and we don't just say, hey, I have a cold. We say, hey, I have a runny nose, stuffed head, my ear aches. When it rains, my left knee kind of shake. Like, we come with everything, and it still seems like no matter what we say, it's put to the back burner or to the side. And how do we address that, or how do we empower ourselves in those types of conversations before you even get into the statistics, right? This is everyday life, which lends itself into even when we go to the doctor.
I think it's about really having a conversation with your elders or just another sister friend, somebody that you can talk to just about what's going on with you. At the Cultural Wellness Center where I work, I'm a health navigator. So before COVID, I would go to doctor's appointments with people and just be another ear that hears what's going on and be able to talk to people. Do you understand, what they said, or do you have any other questions? And so being able to have an elder or just someone who can go with you, even if it's virtually on your phone, just so somebody else is able to hear what's going on, and if you have any questions, be able to encourage you to ask. At least that's what I think. I don't know about anybody else.
Okay. So to be able to have someone to help us push our questions. So don't let go of the questions is what I'm hearing in that.
No, definitely.
Okay. Oh, yes. Ask more questions. Yes. I don't think people are asking enough questions. It's like, well, this is what my doctor said. So this is what the midwife said. Well, the nurse said I had to. Well, they didn't let me. Well, I wasn't allowed. Let and allow don't work well for me in the situation. No, you let them do something to your body versus, well, so many people, because our society, we have been groomed to believe that, well, whatever they say, that's what I have to do because that's what's best for me. And so people don't even know, like when I teach childbirth education, I like to talk about this. It's like, when I say you have to have your cervix checked if you don't want to, they're like, what? People act like your cervix is right here on your shoulder. And they're like, let me check your cervix. No, that thing's at the top of your vagina. So the only way you're gonna get your cervix checked is if I put my fingers inside your body. but people don't feel like they have the ability to decide who puts their fingers inside their body because they're in the hospital. And that's like a good example of, yes, ask the questions. Yes, know your rights. Yes, this is your body. And just to be able to move forward from, I didn't know I could tell somebody they couldn't put their fingers in my vagina. Like
Wow.
where do we go from there?
Well, you don't think about that. And then on thinking like, so you don't think that you can say no, right? Because you're at the hospital. And if you do walk away, you're afraid that you're going to still be another statistic. And the statistics are, they're not great. We're 3 to 4 times more likely to die in childbirth than our white counterparts. We face nearly twice as much rates of infertility than our white counterparts. I mean, like, it just gets worse. Like, every time you say another statistic, it's like, all right, so it can't just be us, because we're known for taking care of our bodies. We're known for at least being healers in our communities, but we're not able to heal ourselves or to impact our health decisions. Wow, I'm sorry. And another piece of that is it's fibroids. I mean, I know women who are 18 years old who have fibroids, Black women. So it's not something that, in our minds, we think, well, it's a grandmama thing or an elder thing. But as young as 18 with fibroids, what is that conversation like when you're dealing with childbirth and fertility? And how do we bring that into the conversation? How do we even know we have it? How do we know to get checked?
That's a great question, because if I was 18, I wouldn't know either. It's essentially what Rhonda said. It is asking questions is really important.
Okay.
And asking, how can I get checked? And how can you get checked is having an ultrasound done. Really, that's the best way to see how many fibroids you have, what size they are. So yes, continuing on what you said, yes, asking questions is very important.
Now,
having a conversation. Yeah, I'm because what I'm thinking about as far as that goes with fibroids and fertility, I'm thinking of us, even just our young women, our very young women, less than 18, beginning to have those kind of mother-daughter kind of conversations, having the spaces and places where people can come and even just begin to talk, so people can start asking the questions. And so starting with our young girls, our young sisters, being able to really educate them about their bodies so that they are comfortable with talking and asking and having those conversations with elder women around who had many different kinds of experiences, and being able to do teaching of the young sisters, and then with even the mothers, being able to talk to them too. And so those are different kind of circles that people should start. And I really want to do something like that, but I want other women too to come with me on that journey, to be able to start those kind of circles. Because everybody's always saying, ain't nobody else's business what happened. I don't want no help, but
we need help.
We need help. You need help. It's pastime. I can remember taking my daughter to something, even though she was embarrassed. She was 9, but it was a conversation that we had to have, and it felt good to be able to get that support. I can remember those kind of things happening when I was growing up in elementary school. My mother coming to the school, taking the day off from work for that kind of conversation with the mothers and the daughters.
Yeah, I even think like the process of, oh, it's your period, it's supposed to be bad. Yeah, no. And
I don't think so either.
Yeah, and so, but see, because we as a society think that, so someone who has periods that are the cramping that takes over their life, where they're always thrown up, or they're always curled up in a ball, or I have to take days off, or I have to get a prescription medicine, or I'm bleeding for 10 days or 8 days.
Ooh.
you know, like all of that. I feel like we say PMS and then the things that happen on your period, it's supposed to be bad. You just do what you can. And it's like, no, but if we knew that those things actually are not, they might be common, but they're not normal. We know that they're not normal. It's not what our body's supposed to do. Then we can say, hey, don't give me estrogen just to like a birth control, just to like, just take this, you'll get better. No, I'm actually not getting better, and it's like, when we know that these things are not normal, then we can say, hey, I want more testing. But if we think that these things are normal, and then of course, this is only one thing that could come from having fibroids or endometriosis, but when we know that these things are not normal for our bodies, then we will ask a question. But if we think it's normal for our bodies to experience menstruation, then we don't think to ask more questions. Okay, where's the Motrin? We just don't know better. So why would we ask questions if everybody is experiencing this?
That's a big piece. Because I mean, for me, I just like, that's a point of shame, because I didn't know that it wasn't normal, because there's so many women around me who I'm the oddball because I don't get cramps and my period only lasts 3 days. You know what I mean? And they're like, what? Just shut up. Because you don't eat, because you don't eat meat, then that's why that happens. And it's like, well, I've never had this issue, and I just thought I was the odd one, and you just told me that it's not normal. So ladies, all my friends who are watching this right now, it's not. Stop looking at me. talk to somebody else about this. No, but that's really real. How then, but thinking of all these pieces, what can we do then? Because we see it needs to start young. How do we proactively, either for ourselves or for our children, even help them with those conversations and with an OBGYN? How do we go about selecting an OBGYN? And what is the importance of that relationship?
I think word of mouth is important. And talking to women that you trust, finding out their experience with their physicians is very important. So I think, yes, talking to other women that ask them about their experiences with their obstetrician, their experience with certain facilities, clinics is very important, because that will really help guide you, because there's no one great resource to point you in one direction. It'd be nice if there were, yes.
Okay.
Well, we do have the Earth app that just, it's a national app. It's IRTH, it's birth without the B, birth without bias. And it's new. And so even though that may not help you find the gynecologist outside of pregnancy, but you would still learn about the local OB-GYNs. And it is where people who have had babies, they're looking for people in the last year, especially to write reviews in this app of their birthing location, their provider, the lactation specialist, the nurses. And the purpose of it, the way I understand it, is to help people find the safe places to birth. Well, a lot of the people who catch babies are the same people who are the gynecologists or the women's health practitioners. And so you can still learn from that. So really trying to push the Earth app, IRTH, because it's only been out a couple months, but Kimberly, I don't know how to say her name, Seals Ehlers, I think is how you say her name. She wrote the book, The Big Letdown. She's the one whose app that it is.
Okay. Well, we'll definitely check that out and share that with our readers as well as another option, because it just feels like you're kind of left out there. And even when you get health insurance, health insurance even feels like it's just for men. Like you have to, this basic health insurance does not include anything dealing with being a woman. Like fertility, maternal, childbirth, just the delivery even being covered. I didn't even know that. Someone said, look at that. Make sure your health insurance covers you even giving birth. Like, wait, what? That might not be. Okay.
That's an interesting point you make, because today, okay, I get my days mixed up. Today or yesterday, there was a doula who posted in one of our doula Facebook pages, hey, have you heard of this? My client said they found out that the hospital they're birthing at accepts their insurance, but the providers who work at the hospital are not covered under their insurance.
Mm-hmm.
We're talking about in the doula community right now.
Mm-hmm.
Wow.
Crazy. That's
And
crazy.
across the board, it feels like, women in general are left out the conversation when it comes to our healthcare.
Mm-hmm.
And then we see on top of that, as Black women, we continue, it's like we just get hit. And then it's like we're not told to talk about it because Black women aren't supposed to be infertile.
Mm.
Do you understand?
Well,
like that's part of womanhood. Let's talk.
That's all about slavery right there. We can go back.
All the way back.
Very true.
Think about if you go home after the age of 30, it went from you needed to be married to have a kid to, we'll just, if you just have a kid, it'll be okay. We'll take care of it. To, are you going to, honestly, for me, I just had to tell my family, so trying not to be rude, but just please stay out of my womb. And they were just like, wait, what? Because I didn't know what else to say. Just like, it's my womb, please stay out of it. You don't even know. And I think these are the conversations that we have from the period up until menopause. How do we empower ourselves in that conversation even further? And what are you doing that we can connect onto to reach out to you for? Because right now you three women are I'm pretty impactful. So
yeah.
I just think it's word of mouth. I meant really just talking. Because I know that I'm here for whatever kind of conversation, especially around birth and birthing, and just even being able to support people through loss also, losing an infant or people losing a birthing woman, being able to talk with people and support people through that process, because it is a process. And losing, an infant and really working. I think I know that here I was on the infant mortality review, and it was sad for the African American community. They gave us names and they wanted us to go and interview people, who had lost an infant, really find out, why they thought it happened or what happened around it. Most of the people that were on this list that they gave was probably close to 50 people. Most of them were in shelter down at PPL. And it was like, they gave the list to you a year later. Who's going to be still at the shelter a year later?
Right.
And why do you think they lost their infant? They were in shelter, And so really thinking about just infant and maternal mortality. And because you don't have to be poor and lose a baby. You can have gone to an HBCU or just any kind of college and still be treated really bad. And you can lose your baby or lose your own life.
Right.
Yeah, the rates don't change based on education. There's nothing that changes. Not education, financial status, even marital status. That's crazy. It's not, if you got a husband, you think it'd be better. Nope. Because
it's not about the person. It's not about the pregnant person. It's about the system that we birth babies in.
Right.
And because the system isn't changing, percentages or the rates are not getting better. And so when we can expand our mind and allow ourselves to believe that this is systemic oppression, this is systemic lynching, this is systemic abuse, then we can understand why a person who makes 6 figures or 7 figures who's Black can be a statistic. Well, because it's not about the individual person. And that's where the work has to be done. And I don't know what that work looks like, because if we knew, we probably could fix it. But it's also not our issue to fix. It's our issue because we're the recipients of this abuse. But it's a white people system. And the white people need to fix their system, because all the work that we're doing, it helps us. Like, we're trying to help our people in the midst of their broken system. Well, maybe it's not broken because it's the way it was set up, but it's broken to us. It's working for them, but it's not working for us.
We the round hole. We don't fit. So you say that, right? So wait, did you want to add something really quick?
I think I agree with you. I think the system is broken, and it's not necessarily working for them, especially when it comes to maternal mortality as well. So it's increased for the past 20 years for every woman, but of course our gap, unfortunately, is much wider when you compare us to white women. I think the issue, it's a public health issue. I think the issue is we don't value women. And the fact that we don't value women, that affects the most oppressed women, which of course is us, Latinx women, and Indigenous women. Yeah, I wish, and I know there are people that are working. I know the Maternal Black Caucus is working. It's really, you need policy. We need policy changes, honestly, because we can be doing the work like on the ground. Yes, you do your bias training and all of that, but it's a policy issue. We should have expanded Medicaid. We should have women, be covered postpartum and not dropped off after 6 weeks and they can no longer be seen. Is a big issue, because most deaths actually occur postpartum.
Right. And the whole 6 week thing. Like, if somebody's on a slippery slope,
right,
they done slipped.
Yes.
By 6 weeks.
Exactly.
And the fact that newborns can have multiple visits before that 6 week, but not their parent, is a huge issue. And it's like, how do we, and yes, so we have doulas can step in, we have elders, we have family and friends that can step in, but we can only do so much medically, and I wish that every pregnant person would have their own blood pressure cuff at home.
Yes.
Because, I just had one of my families go in at 37 weeks. I'm like, look, if your blood pressure cuff is right, then this is a Latinx woman. If your pressure cuff is right, you need to get induced. She sent me a picture of 3 blood pressure readings, and 2 of them are 140 over something, which that's very high for especially pregnant. And then the third one was 150 something over, I can't remember, 80 something. And I'm like, no. Like, you're getting close to stroke numbers. But then that's another thing. We need to know what is close to stroke, what's severe,
right?
What high blood pressure is leading towards preeclampsia, And so, like, our system is broken. What can we do to help ourselves and help each other? And one of them is having blood pressure cuff. Well, another one is definitely finding a better provider if you need one. But that blood pressure cuff in your home is huge.
Wow. How, you just said find a better provider, right? Or another provider. How do we do that? Like, what are the things? I know someone in here just in our comments said, ask about Black maternal health. And I don't see a hospital just saying, hey, guess what? We kill this many Black people each month. So do you know what I mean? Like, I don't see that as a thing that's going to be easily accessible. But what are the things that we can look for besides not being heard when we get into the room?
I think it's at this point, I think it's so hard because birth workers know the good providers and
we
the
just
hospital.
coming for y'all. Okay,
the people don't talk to us until it's 4 weeks before they get ready to have a baby.
When we supposed to talk to you?
I love it when somebody comes to me in their first trimester. I love it when somebody comes early in the second. That helps me be able to get to know you. Yeah. We can talk. You learn to trust me. We know stuff. That's what I like. I think the earlier the better.
Yes,
is helpful, because then you can talk about people's birth preferences, not no plan.
No, not the plan. Yes,
what they prefer to have to happen when they have a baby. We can talk about that.
Okay. All right.
I definitely call them best wishes, birth wishes or birth preferences. That's as far as we get, because we're baby's in charge. So whatever happens, whatever the baby decides that's what we're gonna do.
That's right.
Mhm.
That's right. Babies
But
know what they're supposed to come here.
I would add to what Mary said is do your research. And I know Dr. Cool said that earlier, but part of doing your research is interviewing providers. Like, you gotta go in with a list of questions. And I tell people like who take my class who don't know who their provider is, or if a client tells me a provider that I'm like, and we need to talk about that. It's like, okay, well, let's come up with a list of questions. My clients they have a page of resources and it's a list of questions on there. And then you pay attention to how they answer.
Mm-hmm.
If you're getting red flags in the clinic, why do you think you're not going to get red flags during your birth? And that's not the time for that added stress. And so you have to interview people. And then if it don't feel right, then you need to go. I had a client, honestly,
I agree.
So during labor, fire the midwife in the middle of the night. And I get a text because I hadn't gotten to the birth yet. So we fired the midwife. I'm sorry, you did what? Oh, I'm proud of you. For whatever the reason was, I'm proud of you for standing up for yourself. But we have to interview and then stay flex in the midst of your birthing experience if things need to change.
Mm-hmm. But
I
also,
agree.
too, if you see if you're in a clinic that has a lot of OBs, you should try to see all of them.
Mm-hmm.
If you have a midwives, you should, and they are like a collective or whatever, see everybody, because you might not know who's going to be at your birth. And so being able to see everybody so you can feel their vibe. And if there's somebody that you don't like, that's going to be the person that's going to be at your birth. And so if that's who you bring to you. So
it happens.
Don't be the one. It happens.
It does happen.
That's right.
So, thinking about this, even with we talk doulas, right? Generationally, this was an expected thing, that there was always someone there that helped. And now it almost seems like it's a luxury to have a doula. Oh my God, like I have a doula. do you know, like this conversation, how do we bring this back to normalizing for us, especially in our communities when we've been doing this?
I think it's difficult to convince our community that they need support. Well, I got a midwife, so I'm fine. Well, my mom's going, so I'm fine. And maybe your mom is fine. I'm not saying moms are not fine. But oftentimes, these are the types of things we hear, like, I don't need birth support, XYZ. And it's like, so does your mom know what to do if your baby's in your back and you feel like a Mack truck is in your back? Does your mom know how to help you encourage the baby to move? Like, that's like, I want people to understand that doulas are not just there to hold your hand and smile at you if you're crying. Like a good doula has some skills to help with positioning, or based off of, if Dr. Cools is in there and you agree to have her check your cervix, and Dr. Cool says, your cervix is this, this, and this, and the baby's in this position. As a doula, I'm already thinking about what we're going to do based off of that information, right? Because I'm skilled, I can say that I'm skilled in helping, not just helping you cope and you to feel good about your experience, but okay, well, let's go ahead and figure something out here. Like, or check your cervix, and your cervix is only on this side, but the rest is on. So now I know what I'm going to do to get rid of that last little bit of cervix. Does your mom know how to do that? Can you take a class so she can learn? I'm serious though. Like, really, you should take a class because, this wasn't your question, but our surgical birth rate is off the chain. And so, in this country, we're 32% right now. I just looked at the CDC.
Yes. C-sections?
32%. You walk in a house with a baby, you are 1 in 3 chance of having a surgical birth in this country. Yep. And the average in the Twin Cities is about 28%. That's the same as 32 in my mind. So, and I'm not saying that's a doula's job to keep you out of a surgery, because some people need a surgery, but most people don't. Yeah. And so let's put that out there too. We don't need to demonize anything. We need to stop demonizing surgery, stop demonizing Pitocin, stop demonizing epidural.
Right, that's true.
Epidural can save you from a C-section sometimes.
Yes.
So, having an understanding of when things are appropriate to use. And oftentimes our family members and our spouses don't know those things. They can learn them, but oftentimes they don't know them. But a trained birth worker, that's the stuff that's going through my mind at your birth. And so that's why we need trained birth support.
Now and have somebody that looks like you that's in there.
Yeah.
But you see how there's this communal conversation right now, right? Dr. Cools is cool with you being in the room. Right?
Absolutely.
Yes.
Because I want a healthy mom, healthy baby. And I tell my patients all the time, I do not love doing C-section. I want a vaginal delivery as much as you do. So all the help in the world is much appreciated.
You are not the majority.
And I've worked at a couple. I've worked at a couple places before landing here. So I've been in the Twin Cities for just a little over a year. Before this, I was in Florida, and so yes, the atmosphere definitely is different depending on where I am practicing.
Yes.
How do we address that issue when, I found some coins to get a doula, because that's a whole nother piece. If we talking about the birth is not included in the health insurance, right?
No, it's not.
So if we just talking about just the actual birth not included, I don't know why the doula would be included. So now we got you, and we're trying to bring you back to the hospital. And how do we even have those conversations so there isn't the problems or because then there's been tension. You hear stories about tensions in the doula and the doctor fighting, and it's like, wait, what? How? But it's me.
Well, there's certain kind of
things there. She just said a lot.
Certain doulas that have there's all different kind of doulas.
Okay.
And I usually tell people, I say, I know a lot of doulas. You can interview me, but you might not like my vibe. You can go with somebody else, and I will happily turn you over to somebody else. Right? And that, I think that goes for postpartum too, like postpartum. So there's all different kinds of doulas that are out there. But if a hospital or if a certain nursing staff has a hard time with one doula, they'll put everybody in that same category. Am I right?
True.
Yes. And some, I will say this as well. We have a lot of providers, nurses, doctors, midwives who love doulas. And then we have some who are abusive towards doulas as well. Yes. And so though I've never been touched, I have been yelled at. But I do know of doulas who have been pushed or hit by hospital staff before. And so, and then sometimes we walk in and you don't know if someone's having a good day, and then you got to butter them up, and then just so there's no tension. And so yes, sometimes we walk into an environment as a doula, like, how do I try to soften this space? So there can be, yes, some rogue doulas in the eyes of medical staff, and then sometimes hospital staff are just not nice at all. And so then, I actually warn my clients going into the birth, if you feel like they're racist towards me, or if you feel like they're not treating me well, I want us to focus on the birth and let's deal with that later. Right. And that causes trauma for families when their doula's not being treated well.
That's a whole other level. Dr. Cools, how do we prepare to come see you? Like, what are things that you wish that we were doing at home? And we got the list from Rhonda.
Okay.
We got the circle from Akmiri. And now we're coming to you. What else needs to be on this list or of actions and things you wish?
Seeing your obstetrician before you get pregnant.
Yeah.
Because I tell people, you want to be in the best physical condition you can be in prior to pregnancy. Because I say think of pregnancy as a stress test. This is the most stress your body will be under probably your entire life. So you want to be as healthy as possible. So I would say, if you know you are interested in becoming pregnant, see your doctor. Because you want to find out if you have any issues, like if you have heart disease, you want to know that. You want to start treating that. If you have high blood pressure, you want to be diagnosed with that and start treating that. Or diabetes too is very, very common, and just not knowing you are a diabetic and finding out during pregnancy. And so that kind of unfortunately kind of puts you a little bit behind the 8 ball. So seeing an obstetrician even before you get pregnant is a great idea.
Okay. So we got to be from day one on our health, and then in figuring out how we get to have, some people have the family doctor and some people move a lot, so they don't have the family doctor, right? But that's big to know that we still need to have that. I'm going to be honest, like I moved to Texas and I still don't know who my primary physician is. Do you know? It's like, oh, well, I guess I got a couple months, I got to do this, right? But that happens for a lot of people, that we don't do it in a new space until something goes
until
wrong.
you need something. Right.
And we have someone in the comments that asked about epidurals, because we talked about this a little bit earlier, and just wonders why epidurals get a bad rap and why they're considered bad. And are they? What kind? Let's see. Yep, he just says, why do people talk like epidurals are so bad? And why is it bad for birth? Or is it bad for birth? Anyone have any?
I don't know. I don't know why there's this connotation that epidurals are bad. Now, I have definitely had patients tell me that they have heard from someone or someone in their family, like, they got an epidural and then immediately needed a C-section to deliver, or, back pain after having an epidural. So I feel like there's just a lot of mistrust with epidurals. And what would be what I've tried to do. So for patients who have questions, I don't place epidurals. Our anesthesiologists place epidurals. If you were in the hospital setting, I have them come and have a long conversation with the patient about what exactly are you doing too. When you place an epidural is very important for patients to know and have a conversation with them. But where the connotation that it's bad comes from, that I am not clear on.
Okay.
Yeah, it is. It's from family, or your friend. I had one, and I never thought, this back pain will never go away. People will say things, but as Rhonda had said, it can save from having a C-section. If somebody is all in their head, they're worried, they can't let their body rest.
I agree.
They're not listening to you about, just breathe sometimes, and people are tired. And so an epidural will help somebody sleep and be able to get back on it, let their body rest and be able to start really processing.
I agree.
And so it can save someone and put someone in the place they need to be able to push.
Awesome.
Yeah, and I would say that I've heard doulas, as we share stories with each other, there are a lot of families who felt pressured by the medical staff to get an epidural they didn't want. I witnessed it a couple days ago. And so there are a lot of people who had epidurals who leave their birthing experience traumatized by the pressure to get the epidural that they didn't want, and they finally did it, and they just felt like that's not what I wanted, but I felt like I didn't have a choice, and I just want my baby to be safe. And we do have an issue in hospitals with hospital staff using the health of the baby to convince people to do things they don't want to do.
Yeah.
Well, don't you want your baby to be safe? I'm sorry, excuse me? What are you saying? Or, things like that, any version of that. Well, it's whatever the topic is. I mean, I could give lots of topics and we don't need like that. That happens a lot. That's not like, and the family I saw it too recently was a white family. And so it is just, that's just one of those things. So it's like, well, if you're pressuring me to do that, then if I take a nap, what are you going to do while I'm asleep? Or if you're pressuring me to do that, then what else are you going to pressure me to do that? Well, if I get the epidural, I know you're going to turn on Pitocin, and I already said I don't want Pitocin. Well, you can't feel it, so might as well ramp up the contractions. Well, I don't want my, whatever it might be. And so there's some of that as well, that goes into it.
I agree. We have to do a better job and change the culture on labor and delivery so that patients don't feel like that. It should be an open environment and an open conversation between the staff and patient and their family. You're right. I have definitely seen that happen. It does occur. Having an advocate with you at your family to help you stay with your preferences is important, but we definitely need to change that culture.
Mm-hmm. See, I mean, my sister's a nurse, RN, and still in delivery room is battling her doctor.
Mm-hmm.
You know what I mean? Like when she had her, her last, it's like the idea that you're still battling with, this is my body and I know what I want, and it didn't even matter that she's, in the healthcare system and working with folks every day, giving them a voice. And they're like, yeah, that's cool, but this is what I do. And so you're going to do this. And she just walked away with some issues with that. And I'm just wondering, like, how do we, I know that we're supposed to advocate and push, but sometimes I feel like all my life I had to fight. You know what I mean? Like, and I hate to say it like that, but I'm just trying to figure out, like, what's this thing that we do it's like, I love the sister circle idea, right? Because I know when my friends, we had the little womb health and was reading, Queen of Food back in the day, like doing all those different things. That's how I got to having a conversation with the gynecologist, because I was reading the book that probably had nothing to do with what I was supposed to be doing in my life at that moment. But it's those pieces, but it's not readily available. It's not readily available in school. Right. It's not readily available in our conversations. Like, this conversation is not a conversation you have at 18, except if you know somebody that died, or except, do you know what I mean? Except if somebody in your family is pushing that. And then at that point, they're pushing it. It's not normalized. How do we normalize this?
Each one teach one. I think we have to go back to really starting the conversation and be okay with it. I think who's ever listening to this call, or watching this on Facebook or whatever, take it upon yourself to really start the conversation in your community with your friends, just in passing, especially if somebody has a younger person around them, just being able to start that conversation. I think, because there's young people out here who really want to know, and I think just with way the COVID has been going around, I've had many of the moms, people I work with, are saying, well, my doctor said I have to be induced because it's COVID. What the heck?
It is that's running rampant.
Oh,
because I had somebody who just started working with it, told me that, and she was just devastated. Oh, I have to be induced. It was like, no, you don't. Let's step back and talk about it.
And what they're not going to do is send a limo to pick you up to bring you to the hosptal.
Exactly.
Induce if you show up for it.
That's what I said. I said, girl, is the baby moving? You okay?
I've actually heard that a lot from folks that, like, oh, well, we scheduled, you'll see it on Facebook. Oh, we're scheduling our birth. I'm like, why are you scheduling it? Okay, I don't know. I'm not a doctor. I'm gonna be quiet. But so this is not a thing, because we're hearing that people can't come into the delivery room with that they're alone in the delivery room. So that could be a thing too. Now, is that relaxed a little bit since COVID hit? Because I have heard of some women giving birth by themselves. I can't imagine that either in the midst of COVID.
At least at the mother baby centers of Alina, we always allowed, with COVID, at least one support person in the room.
Okay.
That has relaxed though. So now you have 2 people in the room, and then the addition of if the patient has a doula or a midwife as well.
Okay.
Mm-hmm.
Okay. So you're
Yes.
not alone.
As of now in the Twin Cities, doulas are in all of the hospitals in the Twin Cities.
Okay.
In most of the hospitals, the second person can only be a trained doula. It can't just be
Your auntie?
no. Your first person can be whoever you want, but the second person has to be a trained doula.
Okay. All right. You know.
Mm-hmm.
My mama and my auntie. Somebody gonna be mad. Okay.
But you know, I just in a doula training I was in recently, there was a woman who took the training so she could be trained to be at her daughter's birth.
Oh, that's
Interesting.
She did. She was there. So, you know, in the Twin Cities, you do have that second person doula. You mentioned something early, Stefanetta, about access to doulas.
Yes.
And so it's really hard to know if people even ever hear about doulas. There's still plenty of people that's never heard of a doula, right? And then if someone is on state insurance, then they can get a doula for free. And
wait, it's covered in Minnesota?
In Minnesota and maybe Oregon. I think.
Wow.
Yeah, it's Oregon.
Okay,
and
everybody take note of that. If you are on state insurance, you don't even got to pay for the doula.
No, you don't. And so it's a process. You have to have 6 visits with a certified doula. They don't take, the state isn't looking at trained. You have to be certified, certain organizations, and then they have to go through a certain nonprofit, let's say. And so one of the main organizations in the Twin Cities is called Everyday Miracles. I know that there are other organizations that I don't know names of. Maybe Akmiri knows. But if someone is on state insurance in the state of Minnesota, they should contact Everyday Miracles if they can't find a doula that they can afford. A lot of doulas have sliding fees, sliding scales, but I understand some people can't afford sliding scales. That's life. And so Everyday Miracles is one of the options if you're on state insurance to get a doula for free. You need to commit to doing childbirth education classes and meeting with your doula.
Which you should be doing anyway. So
yeah.
Truth.
Yeah.
But you know, some people say I want the free doula, but I won't do classes. And I'm that doula that won't do that. Like I'm putting in this work and you need to put in your work. That's a Rhonda thing. But so in Minnesota, you can get a doula for free if you're on state insurance.
And that's called Everyday Miracles? Okay, so we're going to drop that comment in the box too. So.
And at this point in time, I'm doing some work with Hennepin Health, and we have a virtual doula program where it's free. You have to live in North Minneapolis.
Okay.
For that program. And people will get a doula that they can meet with virtually. And it is possible if they're delivering at Hennepin Health that doula can be at their birth if they are open to that. They can be there for that birth. And so even with the virtual doula stuff, and talking with people, I would like to encourage, like if the one support person, if that doula can't be at that birth, if they work with that doula, the doula can at least be able to support the partner and give the partner information and be able to talk to that partner on the phone and talk them through some things best that they can to be able to help support that person. So I want to say that. So we've been playing with how do you really talk with people virtually and how do you connect with somebody, through the camera. So it's about a personality that can make people feel loved through the camera.
Already, you got that down.
Get that skill, learn that skill.
Gotta learn it, yeah.
Well, you all 3 have that down, so that no, but that's great. Those 2 resources are amazing. I'm going to make sure that we drop those in the comments, because even if you're not someone who is pregnant or looking to get pregnant, I know there's a guy in here who's watching as well, because he lost a friend who was Black and lesbian she died during childbirth, and now he's like, I need to know how to process this and who I can help going forward. Because a lot of times we don't know the issues that are at hand until it happens to us or someone in our circles. Even
Yeah. And may I add one other thing? I've done some training also to train men to be doulas for dads, and so actually helping up a father through the process.
So understanding with their mouth open, confused.
I also want to add, before we end, I want to add intersectionality here. So he said Black and lesbian, and the statistics for Black birthing people we already talked about is high. Also, the statistics for the LGBTQ plus community is also high.
Put them together.
Yes.
Right. So that intersectionality as well. And so thinking through what language do we use, right? Not assuming that everyone birthing identifies as woman or mother or she, her. And I will admit it was something that it took my brain a while to wrap around that, but intersectionality is really important. As a doula, I want to be a safe person so that people feel like they can trust Rhonda to be their support person. But there are a lot of doulas out there who can be trusted. There are some, I shouldn't use a lot because I don't know if that's true, but there are some providers, doctors and midwives who are safe as well for Black birthers or LGBTQ plus birthers or Latinx birthers or whatever category in this intersectionality of you're not just a person birthing a baby, but all the other things that can stack up, unfortunately, against you plays a part as well.
So it's a lot of research we have to do on our parts, though, in the beginning, is to really, hopefully, at least culturally, we should have pockets of people that we can connect to and find,
Right.
And it, even when pulling this together, the spokesman called one person that called another person that called another person to put this together. And do you know what I'm saying? So I think that it's that each one reach one, teach one that you were saying earlier. It's like we connect, and I think that we have to be strong in our connections, and it doesn't just happen in one part of our lives. It's not just for a Susu circle.
Yeah.
We gotta folks want to connect then hard, right?
Well, I will say it is in this community, we have a lot of doulas of color. There are a lot of us. I don't even know everybody, but I know that there's a lot of us. And if people want to know who are the providers of color that I can trust, who are the birth workers, the doulas of color, we can help you find them. Or who are the doulas that can help? The other intersectionality I meant to say is fat shaming. That is real in birth.
Very much.
Who are the doulas who have experience that can help me if I think I'm going to be fat shamed? Who are the doulas that can help me if I think that my ethnicity or the color of my skin is going to affect me? Who are the doulas that can help me if I'm in the LGBTQ plus community and I want to make sure that I'm not going to die because I'm in one of these communities or categories? There are plenty of doulas that cover so many areas. And so I would love, as like Mary said, to help people find the doula that they're looking for, because it may not be me, and I'm okay.
And then we need Dr. Coos to tell us how to find
me. Well, so for those women who are looking for, maybe a hospital-based birth, I want to give at least a glimmer of hope. Yes, the statistics are daunting, but we are trying to do the work. At least I can speak for at the Mother Baby Centers. We are trying to do the work to make our environments inclusive to all, that our quality of care is high quality, good quality of care to all, that everyone is treated the same. There's a lot of retraining that is going on that we are doing. We know that there is a huge disparity. And we're getting information from patients and honestly from staff. We've been talking to administration as well. We are doing the work because we want women to be safe.
That's important. And let's be clear, even with all the disparities, Minnesota still has one of the strongest healthcare systems in the country.
I can attest to that. I've worked in Florida, Georgia, and yes, it is. It is.
It's
leaps and bounds. Better
leaps and bounds
here.
compared to New York.
Yes.
Compared to so many other places. So it's not the end of the world in terms of us coming. It's more along the lines of how do we empower ourselves so we can ask the right questions and to know at that moment, if this is not the place for me, that we can move around. Because I think we get to a place and we see you over there and it's like, oh, she looks so great, but you're almost a mirage because I went to this doctor instead and now I'm stuck here.
Yeah.
You get what I'm
Yeah, and people don't realize that they don't have to birth in the hospital. Like that's a thing too.
Right.
You know, if someone has a low risk pregnancy, then there are options. The Twin Cities has a ton. I didn't even know the number, but it's a lot of home birth midwives and birth center midwives. And so we have such a great variety of options in our community that doesn't exist in a lot of places, even in the US. And so it's just important for people to know that they have options. And if you say, well, I don't know if I'm high risk, I don't know. Well, you can have an appointment with an out of hospital midwife and they'll let you know if you don't count. And if you don't feel like your provider, because people are like, I don't know if my provider might try to keep me here. Okay, well, just have an appointment with an out of hospital midwife, you know, and they will tell you if you qualify or not.
Okay. So there's so many options and I love the direction of this conversation. I know we kick in all the time about these statistics related to Black women and our health disparities, but it's so good to know that there are people who are working on our behalf for us in terms of, you know, moving the needle forward and educating us and also helping us empower ourselves. So this is right here, you three ladies, thank you so much.
Thanks for having us.
For coming in. And I just looked at the time. I was like, oh, I got to end this. Okay. So yes, thank you so much. I'm just thinking of even the next time, because I feel like there needs to be a next time that we can get in on other parts of the conversation, you know, and Dr. Cools, no, we get it. We definitely want to be in the hospital. We respect the hospitals. We just want to know that when we come in there, that the people in the hospital are like you, and not necessarily in terms of shade, but in terms of welcome.
No, I understand.
Responsiveness. So, you know, and so this is great. And you standing out here in this conversation also shines a light for your staff and other doctors who are watching like, all right, well, I didn't even think about this because I just do my job, because we have so many implicit biases that aren't, you know, touched upon. So this is such a great conversation. So before we drop out, is there anything else that you would want to share with our audience or viewers in this topic, just to close out? I'm like, no, we did it all, right?
I feel like there's always lots to share. Yes. I would say you have options, you have rights. Get childbirth education by an independent teacher. I'm a big believer in childbirth education series, so that it covers a lot of different topics under one class that might last 3, 4, 5, 6 weeks. But it's a lot of information that's spread out, and finding those independent childbirth educators, I think, is key. And because you have rights, you can make choices, you have options, but when you don't know the options and the choices, oftentimes you don't know how to advocate for yourself, or you don't feel empowered to advocate. Well, I know I don't want this, but I don't know if I can say something. So that education can help you to feel empowered to advocate for yourself.
What she said.
Basically.
Look, that's what it is right now. What she said. I appreciate it. Thank you so much. This was so eye-opening. Even when you think you know something, you don't know nothing. So this is really great. And I hope that our readers tuned in to the MSR Forefront enjoyed this conversation. And again, folks, if you have any other questions, drop them in the comments. If we won't get to them now, but this can spark new conversations, new articles, new communication and content with our community. So Really excited. And again, thank you, Akmiri Sakira Ra, Rhonda Fellows, and Dr. Kathleen Cools. I'm gonna get you an Akmiri Sakira. I
Yes.
want to just add the extra R for in my life. I want to add the extra. I want to say Ra. You know what I'm saying? Because that's powerful. She's like, no, leave the extra R alone, Mama. Thank you so much for this conversation, and we look forward to having you again. And again, everyone else, thank you for tuning in to the MSR Forefront.